Hello and welcome. My name is Jessica Adelman. I'm the Social Media and Communications Manager for the Ehlers-Danlos Society, and I will be your moderator today. For our webinar today, we have Dr. Nigel Burrows presenting on skin manifestations in EDS and HSD. This webinar is part of our ongoing series, Living with EDS and HSD. A quick note about how this webinar is going to work. Attendees are muted at all times. However, you are able to type questions into the question box at any time. Dr. Burrows will not be able to see or respond to any questions until the Q&A time at the end of his presentation. Please do not send your questions more than once. It will not increase the chance your question will be answered. It will just make it harder for us to sift through all those questions. Dr. Nigel Burrows is a consultant dermatologist at Addenbrooke Hospital, Cambridge University Hospital, NHS Foundation Trust, UK. He's a past president of the British Society for Pediatric Dermatology. He's been interested in the Ehlers-Danlos syndrome since the mid-90s when he undertook his MD thesis on the molecular genetics of Ehlers-Danlos syndrome type 1 and 2, which is now known as classical EDS. He is actively involved in the management of patients with EDS and in clinical research. In addition to peer-reviewed publications on EDS, he has written several book chapters on inherited disorders of connective tissue, as well as lecturing on many courses on EDS. He's on the medical advisory board for 2 UK EDS patient support groups and is the chair of our skin working group on the International Consortium on EDS and HSD. Dr. Burrows for being with us here today.
Thank you very much, and good afternoon, or I should say good evening from the UK. I'm going to talk to you about skin changes in Ehlers-Danlos syndrome. I hope by the end of this webinar you'll have an understanding of the different skin problems in EDS, and that skin involvement is common in all types. And I'll give you an explanation of why skin fragility occurs, and I'm going to use classical EDS for that because I think it's useful to have a handle on sometimes why these changes happen. And then we'll finish up with how to manage it. So I'm going to split the talk into 3 sections: an introduction, the skin features, and the management. And in the introduction, I'm going to do a very brief historical. You may wonder what's the relevance of a historical overview for Ehlers-Danlos syndrome. Some of you may know it, but really what I want to emphasize is that when EDS was originally described, it was the skin features that really gave the clue. And actually, the people that described it were dermatologists. So skin is a really important feature of Ehlers-Danlos syndrome. As I mentioned, I'm going to mention a little bit about collagens because that's the biology of collagens gives us an understanding of what's going on, and then the skin features, and then how to manage those skin features. So when you look at the definition of EDS, you'll see already in bold, I put the skin hyperextensibility as one of those cardinal or absolute features that we really expect to see. And also I've underlined tissue fragility, and that includes skin fragility. So skin manifestations are a really important aspect of this group of syndromes. And in regards to the historical, it was actually the literature suggests that Hippocrates in 400 BC was the first person to describe Ehlers-Danlos syndrome. But when we start to look at the more recent literature, and we're talking about the mid-1600s, it was a Dutch surgeon, Van Meekeren, who really gave the first description of Ehlers-Danlos syndrome. And you can see a pictorial from that, and you'll notice that the skin is hyperextensible. And this was a 23-year-old that he described with us. What was a bit unusual is that his hyperextensibility was localized, suggesting a very unusual sort of discrete form of EDS. But as you can see, the skin hyperextensibility recognized way back in the mid-1600s. And then it was a Russian dermatologist, Trigonobov or Trigonobov, depending on how you pronounce and spell his name. It seems to be in the literature 2 different spellings. He was a dermatologist, and really it was this gentleman back in 1891 that first described the clear features of EDS. He published in Russian, and you can see a little bit of chunk of that literature that he published there. Because it was published in Russian, it didn't get widespread coverage, and therefore the syndrome in the West really hasn't been recognized under his name, but in Russia it's still called Trigonobov syndrome. And then you'll be aware, of course, of Ehlers-Danlos, both dermatologists, and they both described the skin features. Ehlers, a Danish dermatologist, described the changes in 1901, and Danlos, a French dermatologist, in 1908. And again, they describe skin and joint features. Sorry, so if we wind the clock forward to 2017, we've now got the most recent nomenclature or classification, but it's been through two iterations before, the Baiting classification and the Villefranche classification. But now we are all getting familiar with the 2017 classification, of which there are 13 subtypes listed here. And as you may be aware, they all have a genetic basis, except for hypermobile, where the genetic underlying faults not yet known. But this table, I think, is helpful to illustrate that they all have skin features. And I'm not expecting you to read all of this, and I'm not going to go through every type in detail, but really this slide is to illustrate that actually all EDS types have skin changes, some less so than others. And I've highlighted in classical EDS the main features that occur. And you can see that that's to do with soft skin, hyperextensible skin, fragile skin that leads to scarring, and easy bruising. And the others all have variable features of this. So to help us understand why patients with Ehlers-Danlos syndrome get problems with skin, let's just have a look at the skin in a little bit more detail. So this is a cross-section cartoon of the skin. On the outside, we have air up here. We have a top layer called the epidermis. Then we have a middle layer called the dermis, and below that, the subcutaneous fat. And in Ehlers-Danlos syndrome, the problem in the skin occurs in the dermis, where you've got fibroblasts. These are cells that are busy producing collagen and elastic fibers. And you can see this sort of on a low power electron micrograph, just showing these bundles of collagen fibers tightly packed into the skin. And this is a hair coming out of the surface of the skin. And so we're interested really in the dermis. So if we look at this in a little bit more detail, we can see that this is, as I showed you, the electron micrograph. But if we look at what pathologists would often look at the skin under H&E, a light microscopy, the collagen is these pink wavy bundles that have been stained. And we've got these little cells, dark cells, which are the fibroblasts, intermixed, producing this collagen. And so if we look at a schematic, what's in this dermis in a bit more detail, we've talked about collagen. Well, collagen, they come in fibers like this, which interlace together to give support to the skin. They're called fibrilla because they have this fibrillar pattern, but there's also elastic fibers and material in between. And so this is all called the extracellular matrix. So we have the collagen I've just illustrated, we have elastic fibers which allow the skin to recoil, and we have ground substances which has got a lot of proteins in there, which we now realize, which we didn't maybe even 10 years ago, actually interact with collagens and help provide manufacturing of collagens, which we call fibrillogenesis. And so with the increase in recognition of the different subtypes of Ehlers-Danlos syndrome, we realize that a lot of these proteins that are expressed in the skin are relevant when they go wrong producing Ehlers-Danlos syndrome. And of course, some of these are present also in bone, and that's why you get skin bone changes as well as skin changes. And the easiest way to think of collagens is it's acting like a scaffolding. It's keeping not only the skin together, it's helping our bone structure, it's helping protect our internal organs. And there are known to be 28 collagens in the body, with not as many in the skin. So I just want to briefly outline how collagen is made. This will take some of you back a while to your biology days, but in the skin we have the fibroblasts that I've shown you, and they produce three types of collagen, types 1, 3, and that should say 5 rather than 4. And they're produced through DNA, which allows proteins to be made which come into the cell, and these proteins get modified by lots and lots of enzymes. Then these proteins join up together, so we have three what's called alpha chains or polypeptide chains, which are assembled from one end to the other, and then they're secreted out into the extracellular matrix, so outside of the cell, with the blue is representing outside the cell. And these little collagen microfibrils join together to form a fibril, which join together to form a bundle. And so they have a very organized way of formation. And this is a gross simplification of what goes on, because collagen synthesis is a very complex procedure, but it helps us understand. And then on electron micrograph, you'll see these collagen fibrils, as we've discussed. So that's a little bit of biology. Sorry for those that was a bit confusing, but let's hope that that helps you understand a little bit what's going on, and I'll come back to that in a little minute. So what do we see in the skin in patients with Ehlers-Danlos syndrome? Well, I've labeled cardinal, minor, and additional. Cardinal means the features that really most, if not all, patients get with EDS. So we see this hyperextensible or stretchy skin, very characteristic, soft and doughy, particularly if you have classical EDS, more subtle with hypermobile EDS, but still there. We see fragility of the skin, and that leads on to scarring, of which there are different types of scarring, and I appreciate these are rather medical terms, but I'm going to show you some pictures to try and explain that for you. We see bruising as part of the fragility, and then other minor features that we see are thin skin and these other medical terms, which I will explain and illustrate for you. And then there are other features we see that aren't yet recognized as part of the classification. Stria is stretch marks and follicular hyperkeratosis, little bumpy changes in the skin. And again, I'll show you what I mean by these features. And what I'd like to do is illustrate mainly with two subtypes of EDS, the classical and the vascular. I'll touch upon hypermobile EDS, although the skin features are not as marked in that subtype. With classical EDS using the 2017 criteria, you will see that the major criteria I've highlighted in bold is skin hyperextensibility and atrophic scarring. We clinicians would feel that you cannot diagnose classical Ehlers-Danlos syndrome unless you have that. And so the criteria really says that you need the number one, skin hyperextensibility and scarring, plus either hypermobility or 3 minor criteria. So everyone has skin changes helping you make the diagnosis. And you'll see a lot of the minor criteria I've highlighted in black are again skin related. So let's look at some of these features. So we have cutaneous hyperextensibility. It is widespread. You can detect it at most body sites. The two that we would tend to recommend for diagnostic purposes is over the elbow and over the volar or the plantar aspect of the hand. If you look at the bottom right panel where it says 1 centimeter, 1.5 centimeters, we would now diagnose classical EDS if you can extend the skin more than 1.5 centimeters at that site, or 3 centimeters at the elbow, as you can see in the top left-hand panel. That's because in hypermobile EDS, there is still hyperextensibility of the skin, but less so. And the other two panels just show the stretching at the neck, which is a very common site to see people do that. It's a less reliable site because as we get older, our skin becomes more lax, and therefore people who do not have Ehlers-Danlos syndrome in their 60s, 70s, and so on may be able to stretch their skin quite a little bit due to sun damage and aging process. And the panel on the bottom left is extension of skin over the knee. As part of the skin hyperextensibility, we also see laxity of the skin, and hopefully you can appreciate that in the top left, where you can see very fine wrinkling over the back of the hand, indicating skin laxity, increased palmar creases, and starting to see the saggy skin over the elbows. Now, I put a warning up with this next slide. For those of you that are a little squeamish, I'm going to show a rather raw wound. So if you'd rather look away, please do so now. So this is a child that had an injury to his leg, and he's kindly let me show these photographs. And you can see, because of the skin fragility, the wound separates apart quite quickly and easily. And this therefore causes quite a retraction of the wound, which is quite deep. Then it's been sutured up, and we'll come to suturing it towards the end of the talk. And he's had a very good result, and you can see the curved scar there. So it was a relatively minor injury that caused that. Anyone feeling squeamish can now open their eyes again. Scarring, very typical at sites of accidents. So in children, that's particularly the forehead and chin where they bang around furniture. Children don't put their hands out as quickly as adults to protect themselves, so they tend to hit their heads a little bit more. So you can see this atrophic, which means thin scarring over the forehead. And then we see a lot of scarring over the knees, and the knees is actually the most common site for scarring in Ehlers-Danlos syndrome. But you can see scarring all the way down the shins with bruising. And then on the right-hand panel, we have what we call horseshoe-shaped scars, and that's fairly evident there. Sometimes also called fish mouth scar, particularly when it stretches, but really they mean very similar things. And again, it illustrates how the skin spreads apart when it's very fragile and torn. Now, the scarring types I said I'd come back to. We recognize most commonly what we call atrophic scarring in EDS. And you can see that over this lady's knees where you get this wrinkled cigarette paper-like wrinkling, and that's the most common. We sometimes see thickened scars, what we call medically hypertrophic. That's less common and often under-recognized. And then we often see, particularly in an elder folk, we see what we call hemosiderotic scarring, where they get this brown discoloration pigment due to blood pigment staining in long-standing scars. And this patient on the right also had varicose veins, seen more commonly in certain types of Ehlers-Danlos syndrome, including classical EDS, which all these patients have had that I've shown you so far. Bruising, very common. Again, the forehead, and you can see that with scarring on the forehead, a larger bruise in this lady on her arm. And then you see it more diffusely on the legs where the accidents tend to occur. And it's very understandable, perhaps, if there's no family history of EDS, and we know that certainly in classical EDS, up to 50% may have no family history, that individuals attend accident and emergency services on a regular basis with bruising and scarring, and they're misdiagnosed as non-accidental injury or a safeguarding issue and mistakenly taken for child abuse. And I'm sure that's a story that may ring familiar with some people. The other interesting thing we see is these piezogenic papules. And I'm just going to put this slide back and forth. If you look at this lady's heels, it lifts her heels off the floor, these papules disappear. If we go back, you can see the papules reappear again. What these represent are little herniations of fat through the fascia. And with the body weight, that pushes these little herniations out. And when the weight is lifted, these herniations disappear. It's not a diagnostic test for Ehlers-Danlos syndrome. You can have these without EDS, but it's another clue to connective tissue fragility. Occasionally, they can be painful, but not usually. This is a rather long-term molluscoid pseudotumors. What these refer to is sites of repetitive trauma get these firm bumps. And the one on the left is a child that's got a very early lump on the knee. Man on the right has got more extensive lumps on the knees and multiple. And these are fibrotic reactions that occur at sites of trauma. And it appears that what's happening here is if there's a bruise, the skin heals with scarring, the same site gets injured again, the bruise again, a bit more bleeding, a bit more scarring, and so it builds up into these fibrotic lumps. And I sometimes get patients asking me, well, can these be surgically removed or should they be? Ideally, we would leave them alone unless they were causing problems, but sometimes they can get infected. Then another feature we see, which we don't necessarily look out for, but this is an X-ray of someone's lower leg, what we call the tibia and fibula, so below the knee. The foot is down at the bottom. You can see these little white marks that are showing up, and this is in the soft tissue. This is actually in the fat, and these are called subcutaneous ferroids. And if you see a large one, you may be able to palpate it as shown on the right, although that's a slightly unusually large one. Normally, they'll feel very small, like pea grains under the surface of the skin. And they're thought to occur due to trauma to the fat causing calcification, because the fat layer isn't as well protected due to the abnormal skin overlying. So they're just an incidental finding. We don't particularly go looking for them, but they're a clue as to the diagnosis of EDS. Stretch marks is something that sometimes gets raised about, will I get stretch marks? Will they be worse? Will I have less of them? Well, stretch marks or strie, there's conflicting sort of frequency that we think this occurs. This is for classical EDS. So study done in 2013 of 40 patients, just over 7% had stretch marks. So the vast majority did not, whereas a more recent paper said that 23% had stretch marks. This is in adults. So it does seem there is a protective effect with Ehlers-Danlos and stretch marks, particularly during pregnancy, which is perhaps not surprising as the skin is able to stretch more easily with pregnancy. However, we do see horizontal stretch marks. This is a young gentleman's back, often with hypermobility spectrum disorders or hypermobility EDS. These horizontal strie, I think they occur more commonly than the general population, but again, you can have these stretch marks over the back and have no features of EDS. It's not a diagnostic sign. I put this in just really for completeness. It's a sign that we just sometimes see where you get these bumpy changes. This is over a gentleman's knee. You can see the scarring associated with bumpy changes, and it's occurring around follicles, and follicles is where the hair grows out of. I'm not entirely sure why this occurs, and I've not seen any good explanations for it, but I've seen it over elbows and knees and over the buttocks as well. It may be something to do with the collagen abnormality around hair follicles. So that's a rush through some of the clinical features. What about just understanding, with a bit of the biology that I gave you earlier, why this is occurring? So I'm just going to take you back to collagen formation, which we call fibrillogenesis, if I may. So you remember that schematic of the skin. We're interested in the dermis. We looked at it slightly higher power on a cartoon where we saw these collagen fibrils. Then if we do electron microscopy, which is really high power magnification, tens and hundreds of thousands of times magnification, you will start to see these individual collagen fibrils join together, and these fibrils join together en masse to form collagen bundles, which makes up the dermis. And I've just drawn this in a cartoon fashion here to illustrate why we get skin fragility in classical EDS. So this is a cartoon showing one of these fibrils made up of little microfibrils which join together, and this is a special type of collagen within it. And this collagen is called type 5 collagen. So we're now looking at it long ways on. So here's it looking end on, here we're looking long ways on. So we've got this type 5 collagen sitting within the other collagens, which are called type 1 and 3 in the skin. And this type 5 collagen has a business end that stands out. This is the amino acid end. And it helps controls how much collagen is laid down in each fibril, so it's nice and regulated. And they want it, you want to have your fibrils at the maximum diameter so they give strength without being too big or too small. And we now know that the gene that encodes for type 5 collagen accounts for up to 90% of all classical EDS. So this type 5 collagen is very important. It actually only is about 2 to 5% of all the collagen in your skin. So it's a very small amount, but it has a very important regulatory role. And this is the collagens looking at an electron micrograph again, looking end on and long way. So this is representing the long way view of looking at that. So if we say, okay, here's normal, nice amount of purple collagen, which is type 5, it gives that nice regular collagen fibrils. But if we've got an abnormality in the gene, what we call a mutation in the gene of collagen 5, means we don't either produce enough or we produce abnormal collagen 5. So we just don't have enough helping keep this all tightly bound together. We start to get an appearance down the microscope that looks like this. And this is splayed ends of collagen. So this is a nice regular collagen. Here's the broad collagen that we're seeing at the end. And some people think of this like looking down at a cauliflower. So they get the nickname where we can see these arrows as cauliflower fibrils. Personally, I prefer to think of it like a frayed end of a rope. So you're seeing, because the rope can no longer be bound tight because it's missing type 5 collagen, it starts to weaken, loosen at the ends, and we start to get weakening. And that is why the collagen fibrils, which join together, aren't as strong, because they're all frayed. And therefore the skin stretches more easily. And therefore when you cut the skin, these collagens can't hold the skin together and it breaks and you get the splitting. So hopefully that makes sense to you why we get scarring. Now, when we look at hypermobile EDS, we still have a degree of scarring, as you can see in the left-hand panel compared to the right, but it's less. So there still appears to be something going wrong affecting collagen somehow in hypermobile EDS. But when we do those high-powered views of the skin in hypermobile EDS using electron microscopy, by and large, the collagen fibers look normal. So it's not quite clear what is interacting and causing the weakness in the collagen, which I suspect there is, but there may be other factors interacting that we have yet to identify. And of course, hypermobile EDS is the subtype. We still don't know the genetic abnormality. I want to move on to vascular EDS because although the skin changes here may not be as dramatic, it's terribly important, certainly for clinicians, to recognize them. And the features that we see with vascular EDS are really easy bruising and thin translucent skin. And what do I mean by thin skin? Well, here a couple of individuals with vascular EDS that you can see the venous network through the skin. And that's indicating that the skin is about a third the thickness it normally would be. And you can see it at all body sites, but this is a child stretched over, touching her toes to make it clear to us that the skin is very thin. This is someone's knees, and this is the right chest of a girl with vascular EDS. And in addition to the thin skin, you can see bruising, because there's real vascular fragility in this condition. And the reason you see the thin skin giving rise to visible veins is because the veins predominantly lie at the bottom of the skin, what we call the subcutaneous. You've got the dermis up here, so you're looking through. So if the dermis is thinned, and it usually is about a third as thick, you can see this normal venous network running through. So it's not that it's an abnormality in the veins, it's to do with it being an abnormality of the cover above the veins. Another unusual condition that we see, particularly in vascular Ehlers-Danlos syndrome, but it's not associated with it, is this condition called elastosis perforans pigeonosa. And we do like long names in dermatology, so I apologize about that. But this is a condition where what we're actually seeing, see these annular rings? They look like fairy rings, and they do spread out like that. But what's happening around the margin of these rings is elastic fibers are being pushed through the skin. So somehow there's a perturbation between the collagen and elastic in vascular EDS, and it alters the elastic ratio, and the body tries to get the elastic fibers out and tries to get rid of it, a bit like it would with a splinter. And that's what we're seeing. It's uncommon, but it's a part of the phenotype, or part of the characteristic skin changes we look for. It's not exclusive to vascular EDS. We do see it in other scenarios outside of Ehlers-Danlos syndrome. So the problem in vascular Ehlers-Danlos syndrome is due to reduction in type 3 collagen. And type 3 collagen is like the other collagen I showed you, it's made up of microfibrils, fibrils, and fibers. If you're not producing enough type 3 collagen, the concern is it thins the skin, because it's in the skin. It's also around blood vessels, both in the skin and internal larger blood vessels. So that's why there's risk of fragility to large blood vessels. It's also found in the bowel, and also in the uterus. So these are all sites that are prone to fragility due to reduction in type 3 collagen. In hypermobile EDS, I've alluded that the skin changes are less. There's a feeling that other conditions might occur more frequently with hypermobile EDS, and I've sort of listed just a few here. Vasomotor changes. By that I mean flushing, redness, burning sensations people describe. Some patients, if they stand for some period, find that their legs swell and go red, and patients who describe urticaria or hives and nettle rash with hypermobile EDS. My personal feeling is I'm not sure that urticaria is more common in hypermobile EDS, but I'm sure you may have questions about that. And people are linking this in with mast cell activation disorder or syndrome. And I still think a little bit of lack of clarity of how frequently these symptoms are occurring in hypermobile EDS. But I know this is an active area of research. I'm only putting out one slide about the very rare subtypes of EDS, so I apologize if there's anyone listening in with a rare subtype, but I'm happy to take questions. But it's just to illustrate, and I've taken this from the recent publication, that other subtypes do get scarring, and this is the spondylodysplastic type and musculocontractural type of EDS on the left and the right, showing that getting various skin changes. But as I alluded to earlier on, all types of EDS have some degree of skin change. So in the last part of the talk, I want to come on to skin management, and I've labeled these all the S's. So all the suggestions begin with an S, so hopefully that'll be easier maybe to remember some of this. So let's start with skin protection. What do I mean by skin protection? Well, there are many ways one can cover the skin to avoid trauma. And here I've illustrated some here. And one has to, I think, balance between protecting the skin and really protecting the child, because often presenters, you know, in childhood, and being overprotective. And I think it is important to get that balance right, and that's up to each individual patient, up to each individual family and parents to decide how much protection they want to give. But on the left, we can go very simple, and this is just using tubular cotton bandages. This is one make, and this is not the only make, but this is neoprene protection. In fact, this is the same girl who's kindly given me a slide showing her using a wetsuit when she's on the beach to protect her legs, and she has classical EDS. Using a bandana can be helpful to protect against trauma to the forehead. If there's more sporting activities, usually this is a shin pad, can be used. And nowadays there are much fancier knee pads and so on that may be more acceptable to young children and adults to wear for protection. But it is, as I say, a balance between using the right amount of protection and avoiding being overprotective. Another feature that some people have recommended using is thick socks, and these are ski socks. People find wearing underneath can just be enough to help with that shearing force. But we do advise, particularly with the classical Ehlers-Danlos syndrome, to avoid contact sports. That's not only important for the skin, but of course also for people with severe joint hypermobility and a risk to subluxation and dislocation of joints. Avoiding strong adhesive bandages is also important if you have a wound problem. Worth letting the nurse or the doctor know that you don't want a big, very adhesive dressing, because that can be problematical. I'm sure you may have questions on that. Come back to that. Sun exposure reduction I've written. This is important, I think, maybe longer term, because we know that ultraviolet light, and if we divide it into UVA and UVB, UVB is the wavelength that tends to cause sunburning. UVA penetrates deeper, and you remember what this layer is. This is the dermis. So the UVA penetrates into the dermis and causes wrinkling. What do we want to avoid? We want to avoid excessive wrinkling. So it's important to use sunblock or clothing to avoid excessive sun exposure. And it's never too early to do that. And one of the important things to be aware of is there are two SPFs, or SPF to think about and UVA rating to think about. Many people just think about SPF, which blocks UVB, but it's also important to think about UVA blockage, which is the star rating, which is important, and the higher the star rating, the better. So important to think about these things early on. Supplements, the third S, there is anecdotal evidence for using high dose vitamin C. I often recommend between 1 to 2 grams a day for adults, but some people recommend up to 4 grams a day. If one is taking vitamin C, I would just be sure that you don't have a history of kidney stones, because vitamin C can aggravate kidney stones. It is unproven, but the reason vitamin C has come into the thought about possibly being helpful is there a paper back in the 1980s showed that after a year, 2 patients who were taking vitamin C with Ehlers-Danlos syndrome type 6, or what we now call sort of kyphoscoliotic. So this is not classical EDS or hypermobile EDS. This is one specific type. But 2 patients after a year taking high dose vitamin C, the bleeding time improved, so less bleeding and bruising, wound healing improved, and also in laboratory tests, the researchers were able to show increased collagen production from fibroblasts. So we know that vitamin C is a cofactor helping enzymes, which are important for the manufacture of collagen. So there's a good reason it could help, but there are no studies to show that it definitely helps that I'm aware of. So that work needs to be done, but it's a safe thing to take and maybe worth considering. Sorry, I've overshot there. Smoking. That's important. Here's an example of someone smoking with wrinkling. It's another way of damaging the skin. There's lots of studies, and we've researched into smokers looking at skin wrinkling here in Cambridge, and we've identified that smoking, along with many other people, increases skin wrinkling. So perhaps worth avoiding, not only for your skin, of course, but for cardiovascular risk factors and many other reasons. Steroids. Caution with corticosteroids. This is corticosteroids rather than anabolic steroids. Anabolic steroids are those that people take to build up their muscle. Corticosteroids are used to reduce inflammation, can be given orally, intramuscularly, or topically. I'm not saying don't use corticosteroids if you have a problem, because many patients with Ehlers-Danlos syndrome will also have eczema or other inflammatory conditions. It needs to be used. I'm just saying maybe think a little bit more carefully about corticosteroid use. It is hard to thin the skin with corticosteroids, but possible. Therefore, one just has to factor that into the consideration of how long to use corticosteroids. The next S is surgery. Excuse me. So what do we advise about surgery? But before surgery, I think it's just always worth weighing up the potential benefits of surgery versus the complications, particularly for planned surgery. And this is true for the classical vascular, and particularly the kyphoscoliotic EDS, where skin fragility is also an issue. Of course, surgery often has to go ahead, and that is fine as long as the surgeons are aware of the diagnosis, but always think of non-surgical alternatives. But before going on to surgery, there are some things that can be done avoiding surgery if to wound problems. And this is a sort of very rough rule of thumb that I suggest to patients. So if they have minor bruises, ice pack compression, so ice pack or compression, cold compression, and if it's a limb, elevate the limb to help with the bruising. Very occasionally, significant bruises, or what we call hematomas, may need to be surgically drained. On the body, if it's a small tear and it's a clean wound and there's no tension on it, then using wide steri strips could be used at 6 millimeters or above. So the right-hand mid-panel photograph is 6 millimeter width steri strip. Below that is the wider 12 millimeter. You don't want the very narrow ones, you want the broader ones to give a bit of traction. I said earlier about avoiding adhesive dressings, but steri strips don't seem to cause too much problems by and large with people with EDS. Uh, so that's for 1 centimeter length in the body. If it's deep wound, jagged, irregular, then it obviously, again, make sure the wound is cleaned. Then wherever possible, get 2-layer sutures and steri-strips, and I'll come back to 2-layer sutures. But important to use suturing and steri-strips. If it's a facial injury, by and large, I would err on getting suturing rather than just steri-strips. But if it's a very small one, one can get away with steri-strips. Gluing is also possible if there's no tension in the wound. But that's one of the problems, that there tends to be tension in this wound. I showed you the photographs earlier showing the retraction. Surgery, I said about the 2-layer suturing. So the top layer, but they also want a deeper dermal layer. This is what gives strength longer term to hold the wound together. And sutures should be kept in twice as long as normal. And it varies in different body sites how long we keep sutures in. And steri-strips would be applied post-surgery suture removal. So normally we would take sutures out and that would be it. But for EDS patients, we move the sutures in 10 days instead of 5, depending where the body site is, and then put steri-strips on for a week at least afterwards to help try and keep that wound together. There are certain cosmetic conditions which I would advise against. Dermabrasion, skin fillers, I wouldn't recommend for patients. Laser treatment for scarring, I wouldn't recommend either, because there's a risk of this hypertrophic or thickened scarring, as we mentioned earlier. The other thing I have been asked about, I'm not relating to the skin, but relating to laser. Is it good or safe to have laser eye surgery? I have recommended against that, because type 5 collagen, which remember I told you is in the skin and regulates collagen formation of fibrillogenesis, there's type 5 collagen in the cornea, and therefore the risk is maybe you could damage the cornea if there's not good wound healing with laser. I'm nearly finished. I just want to mention about local anesthetic failure. So we do know that a number of individuals, particularly the hypermobile type, find that local anesthetic may not work as well. And this was published back in 1990. Been very little work on this since. A more recent survey showed that up to 60% of individuals may notice a poor response to local anesthetic. And this was hypermobility patients. This was before the new classifications. So hypermobility spectrum disorder would probably be more appropriate there. And it's not uncommon. I always ask patients about anesthetic. It's not uncommon for patients to say, particularly when they have dental anesthetic or anesthesia, it takes longer to work. The dentist needed to give an extra amount of anesthetic. Yet we don't know really how much of an effect is this for patients. We don't know why this is an effect, where local anesthetic isn't having its full anesthetic effect initially. And so it's an area of interest and further research. The good news is that patients who have poor local anesthetic response do not appear to have a problem with general anesthetics. So I'm going to stop there. I just want to say an acknowledgement to the patients and families with EDS who've kindly given their permission to use their clinical photographs today, because of course dermatology is a very visual subject, and it would have been really difficult to illustrate some of the features that I've done today without the pictures. And also, of course, to the Ehlers-Danlos Society for hosting this webinar. So I'm going to stop there and very happy to take any questions.
Thank you so much, Dr. Burrows. We do have some questions ready for you. If you have any other questions, you can type them into the question box at this time, and we will get to just as many as we can in the next 15 minutes. The first question we have is allergy to all adhesives typical for EDS?
Sorry, you cut out, is allergies to all, and then you cut out. What was it?
Adhesives.
Oh, it wasn't, sorry, I wasn't demonstrating that there's an allergy to adhesives. It's just that adhesives by nature are sticky. And therefore, if you have very fragile skin and you have a very strong adhesive dressing, there is a risk that if you don't take that adhesive off correctly, you will pull apart the wounds. So it's not an allergy, it's just the fact that it's adhesive and traumatic.
So if someone wants to find a dermatologist in their area that is familiar with EDS, how would they go about doing that? Is there specific credentials to look for, a specific type of expertise, or any screening questions to find someone who really understands EDS? And is there something that they can look for to set that apart from people who may not understand it?
That's a good question. There's no simple answer to that, but certain things that may be helpful is it'll depend in a way what issue you want to discuss with your dermatologist. If it's surgery, then it's very helpful to get a dermatological surgeon or even a plastic surgeon who has an understanding of how the wound heals, how best to make cuts. If it's a more general approach, then most dermatologists will have heard of Ehlers-Danlos syndrome. I appreciate, the difficulty with EDS is many people are still ignorant to the complications and features of it. But I would hope that most dermatologists are aware of the diagnosis. It's something certainly in the UK that we will teach. Of course, the Ehlers-Danlos Society does keep a list of interested practitioners, so that would also contact the Ehlers-Danlos Society to see if they've got anyone.
Awesome. What about collagen supplements, or is that something that you recommend?
It's not something I personally recommend. I've yet to be convinced. One of the reasons I'm not convinced, and I'm willing to stand corrected in time, but collagens are very large molecules. So they will not penetrate through the skin if you rub them in. You will not absorb them through the bowel. They're too big. So you have to chop up the collagen. And once you chop it up, it's sort of rather inert. It's not going to do anything. You'll just have a little bit of collagen. So it's not going to be an active compound. So it's not going to do anything even if it gets absorbed. So there's no evidence that taking collagen supplements makes any difference.
Do you have anything, can you speak to specific acne treatments that are good or not as good for people with EDS?
Well, that's a very broad question. Acne is an hour-long webinar, which medical therapies, we treat anyone with EDS as we would anyone who didn't have EDS, and that includes isotretinoin or Accutane or Roaccutane we would treat with EDS. I alluded to some of the cosmetic procedures that we would want to avoid if possible. The sort of what we call the dermabrasion or laser abrasion, where you're trying to generate new collagen formation by damaging the surface of the skin. I think I'd want to avoid that because we know that the collagen production isn't as good, so you really are at risk of poor wound healing. So the treatments are the same as for anyone who does not have EDS. It's the surgical approaches really have to be very careful whether you would go into those at all.
Is there anything else interesting about EDS acne? Have you noticed that there's more of it in our population or anything like that that makes it different?
No, I haven't. Even with the scarring, I mean, I think the scarring may be a little bit worse because of the tendency to atrophy or the thin scarring, but I've not noticed any real difference in my patients with acne with or without Ehlers-Danlos.
Interesting. What about tattoos? We have some people who are curious about tattoos and how that might work on their skin with EDS. And if there's any concern with
my
tattoos.
advice is do not have tattoos, but you'll have seen I showed you a picture of a lady with a tattoo, didn't I? For those that can remember, I showed a picture of a lady with pisogenic papules on her heels. She had a tattoo. She had classical EDS, what we would have called mild in the old terminology, type 2. So she had the milder end of the spectrum. She had no problem with her tattoos, but I would be very cautious against having a tattoo because of the risk of side effects with scarring. Also, we know that later on in life, as our skin gets a little bit more saggy, the original nice tight tattoo doesn't look as good. Therefore, you have increased risk of that happening with particularly the classical type EDS.
Okay. We have an interesting question. Do red freckles have anything to do with EDS?
The red what, sorry?
Freckles.
Red freckles. No, there's
Hmm.
no difference in skin type with EDS. Skin type freckling occurs more commonly in people with skin type 1 and 2, so that's the very fair skinned, and that's to do with melanin production, which is in the top layer of the skin. So nothing to do with the dermis where the collagen occurs. So there's no link with skin type freckling and EDS.
Okay, thank you. What about stitches versus surgical glue versus staples? Do you have recommendations for that kind of thing?
A general rule of thumb is to use stitches wherever possible. They do hold better. Glue really only works where there's no tension in the wound. So, and my concern is that most of these wounds will have tension on them. And by tension, I mean they want to pull apart, because I showed you that picture of that wound and of the gaping wound, and that's how quickly the skin pulls apart. So if you imagine trying to pull that together with glue, the glue just wouldn't be strong enough. So unless it's a very small cut, I wouldn't use glue, but glue can be used for small cuts. So steri strips again for very small, non-deep cuts. Otherwise, it's stitch, stitch, stitch.
Do you have any recommendations for people who have trouble using steri strips, either to adhesives or something like that?
If you can't use steri strips, then glue may be an alternative. And if you you can get sort of different types of steri strip. I've used steri strip in its broader sense, but they do come in different types. There are some that are slightly more skin colored that stretch a little bit more than steri strips. So steri strips themselves don't stretch, but you get these elasticated ones which have a little bit more give. I'm afraid I can't remember the trade name of them, and probably not allowed to say even if I did. So you can get different variations of these surface adhesives. So it may be worth just asking in the chemist which varieties they have, so they've got something for the future.
Do skin issues tend to get worse over time? And does that depend on the type of EDS?
The short answer is I think they do. The longer answer is we don't actually know. So no one has done a prospective study of looking at affected individuals with EDS over their lifetime. For sure, we see young kids with EDS and we see adults with EDS. So we've got an idea, but no one has really followed any cohort of patients through to know what the natural evolution of their skin changes are. And I think that's a study that's well worth doing. But the reason I think things get worse as they get older is because you get natural aging, you get photo aging, which exacerbates the changes. But converse to that is, of course, adults tend to be better at protecting their skin than children. So a lot of the skin damage is done in childhood, where kids aren't so careful, they're a bit more clumsy, maybe associated with their hypermobility, and they learn to protect their skin as they get into adulthood. So you see fewer new scars in adults than you do in children. So whilst the tendency is for the skin to become more saggy and aged appearance, the amount of scarring actually proportionally drops as they get older because they're more protective.
What about lipedema or lipodystrophy? Is that something that's seen in EDS?
Ooh. Well, in vascular EDS, there is some redistribution of fat. The mechanism is unclear. So one of the features, and I didn't show a slide of someone's face because I didn't have permission, unfortunately, to show facial features. You do get redistribution of fat. So patients with vascular EDS have deep set eyes, and that's due to loss of fat around the eye. They get sunken cheeks, and often, in my experience, they often have a sort of more square-shaped body trunk due to fat redistribution. That's not a true lipodystrophy or lipoatrophy, it just seems to be a redistribution. That mechanism is unclear because how it links into collagen, we don't know. I have seen patients with lipodystrophy and Ehlers-Danlos syndrome, but I think it's just coincidence that they're occurring together. So, lipodystrophy, I don't think is a particular feature of EDS.
Is swimming in a swimming pool due to chlorine? Is there any problems with chlorine or anything that along those lines that you have any recommendations for?
No, I'd have no worries about chlorine, because chlorine is an irritant for people that have inflammatory skin conditions or skin barrier function problems such as eczema. And we know the skin barrier in Ehlers-Danlos is intact, except of course where there are wounds. But so chlorine wouldn't be any more of an aggravation, I would have thought, to patients with EDS than without. And it's not certainly something that I've noticed or had any patients concerned about. So that wouldn't be a problem.
Okay, thank you so much. That is all the time we have here today. Thank you so much, Dr. Burrows, for being here today and for everyone who joined us. Very informative. This webinar has been recorded. It will be uploaded on our website within the next few weeks, technology permitting. We always have to say that just in case. Our next webinar will be Wednesday, November 7th at 5 p.m. Eastern. Dr. James Black will be speaking on vascular management in EDS. You can look for that sign up later today on our website and social media page. Thank you again, Dr. Burrows, and all of you have a wonderful day.
Thank you.